3 of the sections of 108, and I'm also the course lead. And what I wanted to do is to do an exam review for exam number 1. So that's what we're going to be doing now for the next hour or so. So when we talk about the first exam, remember it covers weeks 1, 2, and 3. We have to remember what weeks are covered, and it's 1, 2, and 3. And you have a lot of information already available to you. Your professors have given you their class notes or their slides. You have the interactive lecture. So please use all of those things also, and the study guide. So exam number 1 review, going to go over the info in the first chapter, important concepts. So myth or fact, and this is your time to weigh in. Myth or fact, are all older adults frail and in poor health? What do you think? Myth or fact? Is it a fact or is it a myth? Nobody wants to join in? It's a myth, somebody put in the chat. Thank you. Most older adults live in nursing homes. Myth or fact?
That's a myth.
Thank you. Yes, that is a myth. Older adults have lower rates of depression than younger adults. Myth or fact? Lower, keyword lower.
Fact.
No, actually it's a myth. Older adults do not have lower. In fact, they have the same, maybe even a little bit higher than younger adults of depression. Most older adults are poor. Myth or fact? What do you think? Myth or fact? Most older adults are poor.
That's a myth. Some of them are rich.
That's right. Introduce me. Who are these people? Most older adults adapt themselves well to the changes of aging. Myth or fact? What do you think? Do most older adults adapt well to the changes of aging?
That's a myth.
Yes. No, that is a fact, Tiffany. It is a fact. Most older adults, most being like maybe the majority of the older adults, do age gracefully. They stay active. They have groups of friends. They have family who are interested in them. And you could see this group of individuals is out and they look like they might have been exercising. So myths and facts about aging are perceptions that we may have heard over time on television. We might have heard word of mouth. And for the most part, older adults are not frail or in poor health. Most do not live in nursing homes. They do not have a lower rate of depression. They are not poor, and they are able to adapt to the changes of aging. So, why doesn't this want to switch? Okay, concerns about aging. Think about your own fears about the aging process. What changes do you individually worry about? What do you think? What worries you about aging? You may have seen people that you know age, and you're developing maybe some preconceived fears about it. What worries you?
I would say poor health.
Okay, Tiffany, I agree. Who else? Who else has something?
I did, Sabrina Young. I say poor health.
Okay, poor health. Yes, because you know, when you see people you know or maybe relations of your friends or some of your loved ones, and they seem to maybe decline and get into a chronic illness, which then gets worse, or they get some type of cancer. So a lot of people do worry about ill health. What fear is the most concerning to the majority of older adults? What fear?
Where they lose their freedom and their independence.
Absolutely, Tiffany, absolutely. Once individual, they fear going to a facility, an extended care facility, a skilled facility, because the gal that is maybe active makes, gets up, makes herself tea and toast. Now she goes to a facility, wakes up, everything is out of her control, her diet, everything. Everything is timed. Maybe she likes to sleep. Well, they're getting them out of bed at 7. You're getting your shower or bath whenever you're on the schedule. So losing your independence is the biggest fear of most older adults. So here we go. Fears about aging, losing the independence, losing control over our environment, losing the ability to make our own decisions. Maybe we don't feel like a big meal for dinner, but that's what they're serving, so we don't have a say in it. We also may fear adapting to a change in living environment. Individual who lives in their own home for most of their life now are taken to a facility because it's deemed that it's not safe for them to be in their own home, taking care of themselves. So here we have this little lady, and she's obviously been transferred to a facility, and she looks bewildered. She has a Band-Aid on her head. She might have fallen at home. So now they're saying, okay, you can't live alone anymore. But she's lost her whole ability to make decisions and to be on her own time frame. Adapting to the different health issues. Older adults who maybe were in excellent health may suddenly be fallen to an illness. Maybe they're in heart failure. Maybe they have gotten diabetes, high blood pressure. Along with all those things come more doctor visits, medication. So the older adult also worries about their health and their income. You see a lot of commercials on television. How long will your retirement income last? Well, that's for people who have nest eggs or pension plans that they vested in themselves. But for the majority of older adults, they're living on Social Security. Losing the sense of who we are is another fear. Moving to a new facility, as we've said, retiring from your career, the career that you associated with who you are. Maybe a teacher, a doctor, a dentist, right? Those people, that is how they envision themselves. So when an individual retires and they don't have that day-to-day routine, going to work, having the respect of the people they work with, that is another fear. Losing a spouse or a loved one. A lot of individuals, a lot of couples are married a long time, and they have that's been their life partner, their friend, and now they lose that person, and along with that goes their whole identity as part of a couple. And with older adults who lose a spouse, their friend group usually doesn't include them anymore. So that's another fear. Residential options for older adults. Here we have an older adult woman, and it looks like she's been getting her personal care. She's happy, everybody's happy. So there are community-based residential facilities, assisted living. The older adult will perhaps have their own room, maybe a little efficiency apartment. And assisted living means there may be a nurse on staff to help with medication. There may be a kitchen staff who provides the food. So that would be an assisted living community. Pardon me. Skilled nursing facilities. Those facilities will take care of the needs of the older adult, the medical needs, the personal care needs, food needs. And how are they paid? They're usually paid from Medicare. And then what Medicare doesn't cover, it would be either personal pay, the people have to pay it, or perhaps they can get some help with medical assistance. So skilled facilities, any medical needs, if the individual has need for physical therapy, it's provided there. Occupational therapy. So that is more of a structured environment, again, as we talked about with fears of older adults. And the primary benefit of either of these types of situations is that there's someone who is checking on those older adults. Medication might be administered. I have to let another student in. Okay. All right. So defining our attitudes about aging. Ageism. What does anybody know about ageism? What is ageism? Well, while you're trying to think of that, think about age discrimination. The word discrimination, right? According to age. And then gerontophobia. A phobia is a fear also. So how is ageism different from age discrimination? Ageism is the dislike of aging and older people based on the belief that aging makes people unattractive, unintelligent, and unproductive. And how false is that? We have a president who's an older adult. We had a Supreme Court Justice, Ruth Bader Ginsburg, who was in her 90s and still sitting on the bench. So are older adults unintelligent? Are they unproductive? No. Are they unattractive? No. And emotional prejudice. So ageism is also an emotional prejudice or discrimination against people based solely on age. So if you're talking about age discrimination, that is the prejudice. They might not want that older individual still working in a company that's trying to revamp to have a younger image. So that is discrimination. Offering him his retirement or her retirement so that they will leave the job. The age discrimination and ageism allows the young to separate themselves physically and emotionally from the older adults and to view older adults as having less human value. When we think about this country, the United States, we are seeing that in action. Older adults are usually in retirement communities, high-rise older adult living, nursing facilities. But if you go to some of the Asian countries, what are you going to see? Extended families living together. Same thing in Europe. The Asian people respect the elders. It's a lot different in this country, which is quite distressing. Does everybody agree?
Yes.
Okay, I see heads shaking. Gerontophobia. Phobia is a fear. People have fears of bugs. They have fears of animals, right? So in this case, it's a fear of aging and the refusal to accept older adults into the mainstream of society. Like pass them by, don't look at them. People don't want to realize that maybe they will someday be that age, right? And that older people have a lot of wisdom. Both senior citizens and younger persons can fall prey to these irrational fears. How do younger people fall prey? Different plastic surgeries, different, men reach about 40 or 45 and they get hair plugs, they dye their hair, they buy a sports car. Their devoted wife of 25 plus years, they divorce her for some younger woman so that he doesn't want to own up to his aging, right? So that's gerontophobia. in the individual themselves. A woman who doesn't want to look wrinkled might get plastic surgery, all kinds of implants and surgeries on her body. So we can either practice it against people, like we want to act as if they're not there, or we can run from aging ourselves. Medicare, talking about Medicare. It's the government program that provides healthcare funding for older adults and disabled persons. Medicare has 4 parts. Part A is hospital insurance. No participatory payment is expected from the senior. When a person becomes 65 years of age, they get a card in the mail that says, "Welcome to Medicare," and they get their Medicare card. So if a person is admitted to a hospital, they might still be working and have their private insurance. They're going to get asked, "Do you have Medicare?" It's the Part A hospital insurance. Part B, it's optional. Note the word optional. Optional medical insurance. 80% of the customary rates charged by providers after deductibles are met are covered. So remember, deductibles, Medicare Part B still has deductibles. And there's also, they're calling it optional because the individual has to pay the premiums. Part A is included in their Social Security. Part B, they have to pay because it's optional. Part C is the advantage, and older adults often obtain this through private insurance companies, and they'll get their Medicare benefits at a cost savings. So they might get what is offered in Part B by a private insurer with a lower rate. Part D is the prescription drugs. Those are the prescription drug plan for Medicare, and they can obtain their medication at any pharmacy. So let's do a little test your knowledge. So Part A, which column 1, Part A, what are we going to match that with in column 2? Medicare A.
Hospital costs and rehabilitation after hospitalization.
Absolutely, yes, thank you. Medicare B.
80% of cost of outpatient services, provider fees, physical therapy, and other costs after deductible has been met.
Absolutely. What about C, Medicare C?
And that one's going to be supplemental insurance that pays for the cost that Medicare does not cover.
Yes, absolutely. And D, Medicare D?
Prescription drug benefits.
Yes. So when you're doing your studying, just go over this. I know that my students had the outlines from the slides for our weekly classes, and I know this was included, but the rest of you, there is a chart in the book. All right, and again, quiz me. The Medicare program that provides for prescription drug coverage is Part A, B, C, or D?
D.
Did I hear D?
D. D.
Yes, that is it. That is it. Okay, Part D. All right, sources of financial support for older adults. What are some of the sources of finances for older adults? What do you think? Some still work, so they might be getting a salary, right? So that's one source.
Got SSI, Social
Yes.
Security.
Would their retirement be one?
Yes, retirement, if they worked at a company that provided a retirement plan or paid to match whatever they put into it. Retirement, Social Security, SSI, so Social Security SSI is for individuals whose Social Security isn't enough for them to live on, so they get that extra supplement. So pension, maybe they work, maybe they have a Social Security, which most people do. And if you've worked at all, you have Social Security. It may be, if you haven't worked a lot, your benefit would be smaller, which then you'd qualify for the SSI. So a major source of income for most low-income adults is SSI, Social Security. That's the extra coverage. Advanced directives. Who wants to talk about what a living will is? So the living will, I'm going to talk about it. The living will is a document that an individual creates, usually with a lawyer. They're usually notarized, and it's your wishes for what you want done in the event that you're unable to speak for yourself. So you might be comatose, get in a bad accident, or you get admitted to the hospital. And on admission, they're going to say, do you have a living will? And they're asking you that because it lays out what you want done in the event that something happens that's unexpected. So if an individual has a cardiac arrest, do they want CPR? Do they want IV therapy? Do they want IV antibiotics? These are all covered in the living will. Then we have the post or most form. This is I'm going to go to the next page because this is a post right here. And this is a physician's orders for life-sustaining treatment. This is green. I think this is the color of the post in Ohio. Pennsylvania's is pink. Most states have different colors. I don't know how they determine that, but different color, usually very bright. And people that are admitted to hospice care, some nursing homes also will have the patient fill out a post. And as you could see, it's an order sheet that the doctor will sign, and you're determining what you want done. So do you want full medical treatment? Do you want us to select your treatment, right? Selecting your treatment, they might include here IV fluids, a cardiac monitor, or do you just want comfort-focused treatment? All of these things you would select, and your doctor would sign it, and then that's a doctor order. That's going to go right on your chart in a facility. If you're in the home on hospice, home hospice, or sometimes home care, it'll be right on the refrigerator, so that if in the event that something happens and someone calls 911, when they come into the house, they'll ask, is there a post? And then that would be shown to the ambulance attendants. And then we have durable power of attorney. What does that mean? Durable power of attorney, someone you appoint to speak for you in the event that you cannot speak for yourself in medical decisions. A lot of people, it's the eldest child. Some people, it's their husband. But as with any of this, you can change your mind. You can withdraw the person. You can change who the power of attorney would be. It's not, nothing is unchangeable. The post could be changed. You might have said you wanted full treatment. Now you're going to say, I just want to select my treatment. And as people move along in the hospice process, usually they just go for comfort care. So it evolves as the illness progresses in a lot of cases. Any questions about the post, the living will, or durable power of attorney? Just remember, you could change your mind. It's not forever. You can change your mind. So carrying out the older adult's wishes, this is again about the post and the durable power of attorney. Here's an example that you might hear people speak of this post. I'm concerned because I'm sure if I call an ambulance, my husband will ask, I be resuscitated. If I go unconscious, I want to die peacefully. That's when a post comes in handy. And that person has set down their wishes, doctor signed it, and those are the orders. And it prevents conflict in family members who might want everything done for this individual, and they did not want any of that. Okay, and with the living will, you're spelling out your preferences again. And durable power of attorney, who's going to be appointed to make your healthcare decisions? Elder abuse. So what are some types of elder abuse? What do you
Neglect,
think? Yes, yes. Not getting them their food, not getting them their medication, not taking care of their personal care needs, leaving an individual alone in a home with nobody to help them get food. That's neglect. What else? What about physical abuse? What are some types of physical abuse of an older individual?
Hitting.
Yes, yes, how terrible. Pushing, hitting, pinching, burning, right? That's physical abuse. Also, being restrained is physical abuse. A lot of individuals years back in facilities, they would tie the patient with a sheet in the wheelchair. That's called a restraint, and that's considered abuse. So that's a physical abuse. Verbal abuse, what's that?
like cussing at them,
Oh, yeah. Or telling them that they're worthless. And I wish I didn't have to take care of you. The number one thing that causes older adults to be abused is caregiver stress. The caregiver gets very stressed and they resent all the attention and care that this individual requires. Financial abuse, what is that?
Stealing their money.
Yes, spending their money, having the older adult or the elder person live with them with just the goal of getting their social security and not providing anything with their money, right? And we've seen that a lot. You even see that with trusted caregivers, that they will order items on the person's credit card, not buy the food or the medication because they're using the money. And the older adult is feeling helpless because they need that person to help them. We talked about neglect and abandonment. What would abandonment be?
like completely cutting them off, like not helping them whatsoever.
Yep, absolutely. They need to go to the doctor. They haven't been to the hairdresser. Their dentures broke and nothing is being done for them. But hopefully in some cases, there are, people in the neighborhood or in the immediate area who might notice no one's coming to see this person. So I've seen that recently. We had one in our area and the neighbors did call the police on them. So signs of elder abuse, abusive behavior of family members, pushing granny into the chair, pushing her into the car, signs of financial abuse, the bank accounts are being drained. The individuals are buying themselves new cars with the money. Support for family caregivers, there's respite care. So if we have a caregiver who is stressed, like because they have to care for, they're the sandwich generation. They have their own family. They have the elder adult, and then maybe their parent, their grandparent, and they're in the middle, sandwiched. They have to take care of everybody. So in that case, Medicare allows for respite care days for the caregiver. They get, I think, 5 days a quarter. They could be admitted to a facility for those 5 days so the family could have a break. There's also caregiver support groups. They could talk about their stresses. Signs of elder abuse, abuse in healthcare settings. As I said, being tied into a wheelchair. Here, having the aides handle them, or the nurses handle them roughly. You might see signs on their bodies. What kind of signs might you see?
Like bruising, maybe?
Yes, if they're putting them in the chair. They have their hands clenched around the person's arm. You might see handprints. You might, on occasion, hopefully not, see like slap marks on them, right? Another violation is not allowing the resident to make their own decisions. In, let's say, in the case of food, ordering their menu. You can't fill out their menu. The person has to have some say in their menu. So that's a abuse of the right to make decisions. Theories of aging, different theories. We have biological theories, the free radical theory, the metabolism and respiration process that creates free radicals, which go through the older adult's body, and they can cause cell damage, organ damage. So that's the free radical. The antioxidant theory is that if an individual eats enough of antioxidant foods or takes supplements, that it will help to eradicate those free radicals, get rid of them. The gene theory, whatever our DNA set us up with from our ancestors, that's our genetic DNA, and we might be prone to conditions, diabetes, cancer, high blood pressure, because it was inherited in our genes. The immune theory, older adults have less white blood cells to fight off viruses and diseases. So you might often see that they get pneumonias in the community because they don't have that defense of the white blood cells to fight off in their immune system. COVID is a good example of that. Neuroendocrine theory, as an individual ages, the neurons in the brain become less, they lose them, they lose function, they might have forgetfulness, some cognitive changes, that's a change of aging. And then the wear and tear, that's the easy one, wear and tear. You wear out a joint, you wear out a body part. Someone who's a painter, it's going to wear out the shoulder. It's the wear and tear on that joint. Antioxidant therapy involves taking large doses of antioxidant supplements, supposedly fights free radical damage. The results are not validated by research, and it may cause more harm than good. Remember, any of the herbals or supplements can interact with the prescription medication the individual is taking. And also, supplements and herbals are not regulated by the FDA, the Federal Department of Agriculture, and those substances can vary in. So vitamin C from one company might not have the same composition as vitamin C from another. They're unregulated as far as formulas. Stages of psychosocial development. Erickson, you know, across the lifespan and growth and development, you talked about Erickson. And in the older adult, age 40 to 65, the theory is generativity versus stagnation. Right up here on the steps, generativity versus stagnation. The older individual might retire, but generativity, they're giving back to the community, or they're watching grandchildren, or they're reading with young people in a library. That is generativity. Stagnation, they're just in their apartment, sitting there. They're just caring about themselves. So that is the psychosocial stage for older adults, 40 to 65. So the psychosocial, again, we have Carl, he's 65. He's retired from teaching 2 years. He still likes to mentor students. He's writing a book about education. According to Erickson's theory, why is Carl aging successfully? What do you think? Generativity versus stagnation. He's active, he's around people. You know, if older adults are just left by themselves, they get depressed. They sometimes get suicidal tendencies. So staying active is a very helpful part of aging. Then we have the activity theory, maintaining mental and physical activity. Carl, in the previous case study, Carl is keeping his mind active. When a person is active, they have a sense of value and self-worth. They, as we said, they might be volunteering, mentoring, or contributing to the community. Watching grandchildren is another one. Chapter 4, we have to take right now a quick 10-minute break. If you don't mind, we have to take a quick 10-minute, and then we will be back. Okay, 10 minutes, please. Okay, folks, thank you. Needed that quick break a minute. All right, so here we're going on to chapter 4, health promotion and health maintenance, right? You're promoting your health, you're trying to stay well. Health maintenance means maintaining your health. Okay, why is it difficult for many older adults to change their health practices? And the reason is because health behaviors are learned early in life, change is difficult, and older adults adapt well to aging, but they may have trouble adapting new habits or adjusting to new living, such as in a facility, or new habits. An older adult with cardiac problems maybe now has to follow a low sodium diet. So it's not, it's something he's used to or she is used to. So older adults have difficulty changing because behaviors are learned early in life and carried through. But can they change? Yes, and that's where we come in with health education. So dietary practices for older adults. It's important that our older adult maintains a healthy weight, lower calorie requirements for older adults who are now more sedentary, but making sure the food has high nutrients, avoiding weight loss or gain, staying stable, weight stable, reducing levels of sodium, sugar, and fat, and respecting cultural preferences. So here we see a food label. And important things to notice when you're doing patient teaching: what is the serving size? How many calories in that size? We might think, oh, just open the cereal and pour it in the bowl. No, because everything is calorie counted by the size, by weighing it, measuring it. Also important is to look at the sodium, especially with our older adults who have cardiac problems, fluid retention problems, and patients with cholesterol. They're trying to lower their total fat in their bloodstream in the cholesterol lab reading. They always will look at the fats and the trans fats. So exercise, how much exercise is recommended daily for older adults?
30 minutes?
Correct. Do they have to do it all at once?
No.
No, they don't. They can do 10-minute walk. Maybe they're doing housework. Maybe they go to the grocery store. Maybe they're gardening. It could be broken up. And what kind of exercise is beneficial for older adults?
Walking, swimming,
Yep.
golfing, housekeeping.
Yes, absolutely. Walking, it keeps the bones strong, especially if your older adult has any osteoporosis, loss of calcium in the bone. Dental health, your older adult may have dentures. We have to make sure when we're giving them mouth care that we're cleaning the dentures. Could be soaked, could be with a toothbrush. We also have to look for any cracks. How does that denture fit? Is that older adult able to chew their food with the denture? Sometimes they might need to be relined, meaning they'll put some more plastic up in the roof of the mouth area. Sometimes they can use adhesives. So we have to be careful that when we are giving our older adult mouth care, we're also looking at the inside of their mouth. Are there any reddened areas? What about teeth? Any loose teeth that could get dislodged and they could swallow it and aspirate? So we have to make sure that we're checking, because older adults could be prone to oral cancer. They can also get peritonitis, means an inflammation of the tissues around the teeth, gingivitis, gum tissue, and dry mouth. Xerosis is dry mouth in an older adult, xerosis. Denture care, brushing daily, soaking. And does an older adult still need a dental checkup every year, even if they have dentures? Yes, every year, because the dentist will check the gums. So health screening, exams for men and women. And this is table 4.1 in your book. Mammogram for a woman every 2 or 3 years. Clinical breast exam every year at their yearly office visit, yearly physical. Bone density once at 50 to 60. If abnormal, then they will have to take supplements, vitamin D, calcium, and then they'll probably get a follow-up maybe in a year to check on the bone density. Otherwise, if the first one is normal and there's no family history, they may do another in 10 years. Pap test yearly at the gynecologist or at the primary doctor. Colorectal screening. Colorectal, that's a type of cancer that involves the colon and the rectum. So the cancer can develop in any part of that area in the older adult. Colonoscopy, usually at 50. If they have a family history, that will be done more frequently. It would be done earlier. If abnormal, say a polyp is removed, then they would follow up more frequently. Flexible sigmoidoscopy, that is only examining the lower colon. The prep for the flexible sigmoidoscopy is a Fleet's enema, just to clear the stool out of the lower bowel. The colonoscopy involves a much larger prep. Diet has to be light than NPO. They take several laxatives and sometimes enemas to clean out the whole GI tract. And if an older adult has perhaps a bloody stool, they may be getting a fecal occult blood test. What does that mean? The doctor will give the person when they come to the office visit, the doctor might give them the card. It looks like a little card, like an index card or a name card that you might get from somebody who you go to see. They hand you their business card, and that's going to have a little window. It gets opened. A sample of the stool is placed on that window. There's usually a developer that's dropped onto it, and then the result is read. The person may either have that, take that home with them to do it, or the doctor might just do it with a rectal exam in the office. Prostate screening, older adults, males usually will have a PSA test, blood test, with their yearly physical. They may also have a rectal prostate exam. The prostate, that's the only way it can be palpated, is through the rectum. And the doctor will check for how does it feel? Are there any jagged edges? Is it enlarged? Is the prostate enlarged? Vision test yearly, hearing test yearly, and yearly dental exam. So that's the health screening. For immunizations, pneumococcal, there are two different shots for pneumococcal, 1 year apart. So if your individual has it in 2020, their next one is due in 2021. So it's 2 vaccines 1 year apart. Influenza, how often does the older adult or anybody get an influenza, a flu shot?
Once a year.
Yes, once a year. Tetanus, diphtheria, pertussis, that's called Tdap. That's once in a lifetime, and a booster every 10 years. And shingles once after age 60, and it's a series of 2 injections. And you may have an older adult who says, I don't need the shingles. I had chickenpox, because it's the same virus that causes it. But there is a possibility that even if they had chickenpox, they may still get shingles. So they're advised to get the shingles vaccine. So here's our case study. Mr. Billings is 82, and he's at his physician visit. You're the LPN, and you're reviewing his immunization record. Remember what we talked about on the prior screen. What vaccines will you administer to bring his record up to date? So he had 1 pneumococcal vaccine in 2018, 1 in 2020. Remember, they said 2 a year apart. Even if it's this long apart, that's still acceptable. He had a tetanus booster in 09. We're in 21 now. That's a ways off, right? Shingles, he's refusing. And influenza he had in September of 19. Which of those are you going to, which plural, which of those are you going to administer?
The flu shot and the tetanus shot.
Yes, 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 the flu and the tetanus. And I'm just going to go to the previous screen quickly to just reinforce that. Remember, pneumococcal, 2 vaccines a year apart, influenza once a year, tetanus, diphtheria, pertussis, once in a lifetime, a booster every 10 years, and shingles once after age 60. And it's a series of 2 injections. And they're telling us Mr. Billings says he doesn't need a shingles vaccine because he's had chickenpox as a child, and that makes him immune to shingles. What education would you give Mr. Billings about the shingles vaccine? What would you say? Remember what I just spoke about, that it's the same virus as the chickenpox. And even if he had chickenpox as a child, he may still, if he comes in contact with shingles, he may still be susceptible and get it. So safety risks for older adults. Older adults, their sensory changes, loss of vision, loss of hearing, changes in taste and smell, malnutrition, weight loss, all of those things set your older adult up for a safety risk. Falling, loss of vision, they cannot see the cat or dog that ran under their feet. Lots of home accidents are caused by small pets. Loss of hearing, they don't hear the smoke alarm going off. Changes in taste, malnutrition. Older adults have changes in taste. There's less taste buds in their mouth, and also they take a lot of medication, and sometimes that medication leaves an aftertaste, and the older adult will say, nothing appeals to me. I just don't want to eat anything. And that's usually because of the medication that they're taking. And weight loss. Weight loss could be from malnutrition. It could be because your older adult doesn't have any, they have mobility problems. They're not able to get up and cook for themselves. They have a lot of pain. So decreased mobility with it affects ambulation and range of motion. And your older adult might develop contractures of their extremities. The arm that they hold next to their body, because it had been broken once, might stay like that. Medication safety basics. Mr. Jacob Jones is 78. He lives at home with his wife. He has type 2 diabetes, hypertension, and osteoarthritis. Those are his diagnoses. He takes insulin, a beta blocker, a diuretic, and baby aspirin every day. He also takes over-the-counter ibuprofen for pain. Recently started taking glucosamine. That's often given for joint health. You've seen that on TV commercials, because his son recommended it for joint health. One of his friends at church has arthritis, and sometimes he lets Mr. Jones take his pain pills. What medication safety measures would you recommend to Mr. Jones?
Not letting his friend take his pain pills.
Absolutely, absolutely. And the other one is checking with the doctor about that
Over the
supplement,
counter
that,
stuff.
yeah, the glucosamine, because that might interact with what else he's taking. He's on blood pressure, beta blockers. So we have to make sure that that all mixes together. Medication safety. How do we prevent the med errors? The older adult should wear a med alert bracelet with their allergies, any high risk meds they're on. That would be like Coumadin, which is a blood thinner. That's a high risk medication. Review over the counter and herbal meds with the provider, the nurse, and the pharmacist. In this case, Mr. Jones is taking glucosamine and ibuprofen, both over the counter. They should be checked by his doctor as, you know, is he able to take these? Do they mix with his other meds? Keep the medication list up to date. Anything that medication-wise for older adults or even ourselves, we should all know our medications and carry a list with us in our wallet, our purse. Discard out of date or unused medication, and contact the provider with any questions. Prompt medical attention. If an individual has any of these things, should they get prompt medical attention? A severe headache that won't go away. Do they need prompt medical attention? Yes, they do.
Yes.
They could be having a stroke, right? They could be having a brain bleed. Chest pain that radiates or feels crushing. Definitely, any type of chest pain needs immediate attention. Loss of consciousness or fainting, another hazard, that another medical symptom that needs immediate attention. And itchy facial rash for 2 weeks. Does it need prompt? Keyword prompt. Does that individual, they've had it 2 weeks, do they need medical attention right now?
No.
That's right. It could wait till they make an appointment with the doctor or call the doctor for medical advice. Difficulty breathing. Does that individual need prompt medical attention?
Yes.
Absolutely. Nausea and vomiting for 24 hours or more. Remember, nausea and vomiting, especially the vomiting, you're losing fluid composition in the older adult, and they already have decreased fluid in their body, so they would be prone to dehydration. So what do you think? If they're vomiting for 24 or more hours, are you going to call the doctor? Call 911 for prompt medical attention, yes or no?
Yeah, because they could have lost a lot of their fluids to keep them going.
Absolutely. Absolutely, and they're taking nothing in if they keep vomiting, right? So they need medical attention. No bowel movement for 3 days. Significant? Do they need medical attention? Say yes. Why? Because an older adult that they're constipated, no bowel movement in 3 days, that could cause cognitive changes. That's why if you're in a facility, they always check for the bowel movements. Did so-and-so move their bowels today? So 3 days is the cutoff. They have to have medical attention if they don't go in 3 days. Sudden swelling of the extremities. Is that a cause for prompt medical attention? Yes, it is. Cardiacs might be in a heart failure state. The fluid is not circulating in their body. They're retaining fluid. Definitely they need prompt medical attention. Home health considerations. Older adults might be using a home care agency. They might have respite services. They might have a paid caregiver. If your older adult is asking you as a nurse in a facility or a doctor's office, or even you might be on the home health team, and they might be saying, I would like to pay a personal caregiver. Well, we have to make sure, is that person trained? Is there any supervision available? What about a background check? What about immunizations? So those are all important considerations for any type of home care. Chapter 5, communicating with older adults. Types of communication. We have direct questions. Where are you going? That's a direct question to Bob. Bob, where are you going? Right? Informing is a type of communication. I'm going to teach you about your new medication. It's Lasix, it's a water pill, and then you would continue. That's giving information. Confronting, you go to the home care patient's home and you notice that there is no food in the refrigerator. And she looks like she hasn't eaten. She's looking a little bit dehydrated, right? Sunken eyes. Skin looks dry, pale. You do a dehydration test on the chest. So you could confront, you don't have any food. What were you eating? That's confronting, right? Asking something that you need an explanation for. Open-ended questions. That's a very common type of therapeutic communication. You have 3 cats. That's an open-ended question. The older adult might answer you and say, yes, we have 3 cats. So open-ended. You don't put the question mark, you don't ask why, when, where, did. You're just stating the fact and leaving it open. Therapeutic communication, active listening. Listening is a big part of communication. This nurse is sitting here and she's using touch and silence with this patient. And eventually the patient may talk to her, may explain what is wrong, but silence is a very good form of therapeutic communication. Just sitting by the person to keep them company. That often helps them to feel that you care about them. Types of communication. What type is most appropriate for a nursing home resident who's sitting alone crying? What type would we use? Here's our nurse, and she's sitting with this patient, right? She's touching and she's listening, right? Sitting alone crying. You could ask an open-ended question. You could just sit and be silent, or you might reach out and touch their arm or hand. A home health patient who says they've been taking their insulin but has high blood sugar. Confronting would be used. An elderly man who says he's having chest pain. Anytime there's a medical symptom, we need immediate answers. So it would be a direct question. Where is the chest pain? Show me where you have the chest pain. And then that would start the ball rolling to get medical attention for that individual. Common communication techniques. Adults with hearing loss. Light touch. Talk to them on the side with the good ear. Make eye contact. You're going to speak in a low voice. Use visual cues. You can use a picture, a communication board. You can, if you're educating on medication, show the bottle, show the pill, give them the handout that you've prepared with large font. Make sure, does that older adult have their hearing aid in? Communication for vision loss. Introducing ourselves to the patient, the client, with our full name and our role. So you're the nurse. I'm Mary Jones, and I'm your nurse today, Mrs. Andrews. And you would call her by her formal name. We would speak slowly and clearly. Pay attention to nonverbal communication. So nonverbal, if you're talking to a patient And what would a nonverbal communication be that the patient is giving you? What if they're falling asleep in the chair? Are we going to continue teaching about their new diet?
No.
Right, no, we would not. So we would use touch appropriately and frequently to reassure our patient, touch their hand, touch their shoulder. But remember, if they're non-verbally communicating, fidgeting in the chair, looking out the window, I've seen patients get up and walk away. That's non-verbal. They're done. They don't want to talk anymore about whatever it is we're telling them. Crossing the arms on the chest, turning totally away, nonverbal. So here's a communication board for an adult with aphasia. They might be frustrated. So if we give them some sort of communication board, this is an example, they can at least point and say they want a drink. They're finished, they're done eating, things like that. So another real simple way for them to communicate with you is one of the small whiteboards you can get at the dollar store or any of the big box stores. So they can write their need on that. Communication techniques. Your older adult is confused or distracted. We would speak slowly, maintain eye contact, one question at a time. We're not going to ask a whole bunch of questions at once, one at a time. Give them time to process and answer. And we'd also want to bring their attention back to the topic. The older adult might want to get up and walk out of the day room. So we would try to ask them, where you're going. We might also, they might say, to my room. We'd bring it back to the topic. We're sitting in here having the activities now. Do you want to sit? Something like that. Ask them to confirm that they understand. Nonverbal, us also, nurses, nonverbal, crossing our arms, looking away, looking at our phone, feeding the client, but talking to our girlfriend over here. Any nonverbal, the patients, clients pick up on it very quickly. And gestures, remember, gestures are oftentimes from a generation, and a gesture that you understand might not be understood by that patient. And we'll try to make eye contact and not point at them or use any type of sudden arm movement also. Nonverbal touch deprivation is common among older adults. Touch can be as effective as verbal communication. Therapeutic touch does not require permission, but nurses should be aware of the patient's response. If you're trying to touch an individual and they pull away, that they don't want to be touched. So we have to be aware of their response. Communication and space. Following types of space. Public space, 12 plus feet apart. Public space might be in the day room, right? You're 12 feet apart from the patients, the clients who are doing the activity. Public space. Social space might be at a dinner table, might be in a game room playing bingo. That would be social space. Personal space, 18 inches to 4 feet, giving that individual that area around them that is free. You're not going to go into their area. But intimate space is less than 18 inches for treatment, for bathing, toileting, giving medication. That is when intimate space less than 18 inches would be used. Communicating through interpreters. If we have an individual who does not speak English, are we going to use a family member as an interpreter?
No.
No, we are not. We're going to get an interpreter from the interpreter list that's at the facility, right? We would never ask a family member to translate medical information. We also want to give them extra time with the translator. They're going to get the information translated. So we have to give them a moment to respond to that and give back their feedback. And we're not going to rush them. And when the information is given, you're going to notice the expression, their emotional response. Any questions? Get this off. All right, that is our exam 1 review. Remember, you're going to have 40 NCLEX style questions on the material, and you're also